The landscape of interest for all of us in reproductive sciences, women's health, definitely includes the visionary and futuristic presentation that we just heard from Lee. The spectrum of activities for all of us in reproductive sciences and women's health also includes the current problems that we have in obstetrics and gynecology. And I cannot think of a better person to present some of those issues than our next speaker, Mary Dalton. Mary is the chair of the Department of OB/GYN and the Willard Rapley Professor at Columbia University in New York. Mary is also a practicing OB/GYN physician. Her specialty is high-risk pregnancies, and she centers on infant issues, fetal issues, but very intensely she centers on maternal morbidity and mortality. Mary is, of course, dedicated to education, dedicated to dissemination of knowledge, not only in New York and in the country, but also across the world, especially with issues that affect mothers' health during pregnancy and its implications for long-term health, hopefully if they can survive, but of course also for the tragic event of maternal mortality. Mary, it's great that you're here, and thank you very much.
Thank you very much, Yoel, and I would just say to Dr. Hood, I'm in. For whatever you need, I want to have healthy aging. So a volunteer, I would like to have my genome, my phenome, whatever you need, I'm participatory. So it's wonderful to be here. This is my very first meeting since January of 2020, when I saw some of my colleagues in the audience at SMFM. And I can't tell you how mood elevating it is to be back and see colleagues again. And when Yoel invited me, I looked at the program and said, Yoel, you have so many scientists coming from all over the world. Why do you want a clinician? But Yoel persuaded me, and I'm here because of you, Yoel. So thank you. I'm having difficulty advancing these slides. I don't know if I'm doing it properly. I have to point. Okay, got it. Thank you very much. I'm yours, Dr. Hood. So as a disclosure, I am on the advisory board for Merck for Mothers, and they have funded my own work in New York, and they committed $500 million towards mothers' care all over the world and have re-upped that for the next 10 years. And I'm also on the board of March for Moms, which is an advocacy organization towards dignity in childbirth and in health for mothers. So just a couple of definitions for those of you who don't deal with this every day. There's a number of definitions of maternal death out there. The World Health Organization is death of a woman while pregnant or within 42 days. And the National Center for Health Statistics published in 2018 our rate here in the US being 17.4 deaths. The first time they had published this since 2007. Now, CDC and ACOG go further than that, and they say pregnancy-related death is defined as death while pregnant or within 1 year. This is so important because many women die after 42 days of age, and especially women with cardiomyopathy. So following women just to 42 days is going to miss a substantial number of maternal deaths. And they further define it into pregnancy-related deaths as those from any cause or aggravated by pregnancy or as management, but not from accidental or incidental causes, which is pregnancy-associated deaths. And each year, most years, the CDC presents their data with ACOG, and also they evaluate the causes of maternal death that we can evaluate over time. And they've really done a fantastic job with that. So how did I get into this? My earliest career, for those of you who know me well, was in fetal medicine. I was so enamored by ultrasound and prenatal diagnosis. I worked with Diana Bianchi and Tim Crumbleholm in Boston, and we were so keen on what we could do to improve fetal life and how to optimize lives of our pediatric patients. But when you get to be chair of a department, you get to advise people about their roles and their jobs. And I had many of my MFM fellows come to me and say, you know, Mary, we'd like you to help us find a job, and we'd like you, I don't want to take call, I don't want to be on the labor floor, and I just want to do ultrasound. And this would happen for a few years, and then I saw the increasing complexity of the women that we were taking care of. Partly this is due to age and comorbidities, but the risk profile of pregnant women who are delivering in our country has, I think, changed dramatically over the last 20 years. So I really got worried about this, and I mentioned this to a couple of colleagues, and John Queenan, who was editor of the Green Journal at the time, said, Mary, I've heard you talk about this. Why don't you write something for me? And I said, John, I'm a fetal person. And he said, no, that would be important for you to write something about it. So I did a play on Alan Rosensfield's work, Where is the M in Maternal Child Health, when he was Dean of the School of Public Health at Columbia. And I wrote an article in 2010 where I asked the question, where is the M in maternal fetal medicine? And I asked what were we doing to reduce maternal mortality and morbidity in a population with what I was seeing as an increased incidence of chronic disease. I can tell you at that time it was not nearly enough. I did get a ton of feedback after that, and thank you for writing it. And one of my colleagues called me and said, Dan O'Keefe said, Mary, great article, but I was disappointed you didn't put forward a solution. So it did give me an idea, and in 2012, when we had our annual meeting in Dallas, I brought together the ACOG, the American Board of Obstetricians and Gynecologists, members from NICHD, all of our professional organizations, and the CDC. And I said, what do we need to do to get there? What is it we as maternal fetal medicine specialists who came into this field to look after women who had complications in pregnancy, what do we need to do to restore our leadership in this area? And we put a plan together, and they're on this slide, and we did a 5-year kind of report card that we published in the Gray Journal. And I'll share with you some of these recommendations. We had 3 objectives. How were we going to improve the training? What were we going to do about clinical care? And what were the research gaps? So in training, what we found out at that point was that many MFM fellows did not have to spend any time on labor and delivery. So we immediately changed that to say that they needed to spend at least a rotation on labor and delivery during their maternal fetal medicine fellowship, and also time in an ICU. And the American board implemented that immediately. We also felt that because some maternal conditions are quite rare, like pheochromocytoma, those kinds of things, amniotic fluid embolus, that case-based learning and simulation needed to be introduced into the curricula for an MFM fellow. And we're very proud that we opened the Vagelos Education Building at Columbia, and we have a fantastic simulation center that's actually run by 2 members of my department, Arnie Avenkula and Dina Goffman. And Arnie frequently says to me, Mary, if we work together, why can't we learn together? One of the issues with simulation is it is fantastic. It levels the infrastructure, it allows team communication, but we don't have that much data on how it affects outcomes. So I think that's an area that we need to evaluate moving forward. With respect to clinical care, the next question was, what do we need to do to improve clinical care? We felt that we needed to have national levels of maternal care. We know that our neonatal colleagues do this very well. There's level 1, 2, and 3 neonatal units. We transfer mothers so they'll be in a tertiary care center, mainly because their baby will have better care. We need the same system for mothers. Then we wanted to develop special guidelines for those common problems that can cause maternal death, like hemorrhage, infection, hypertension, and thromboembolism. and then look at models of care that would give better care to mothers, and I'll share with you where we are with that. This is a recent article in JAMA looking at where women deliver. There's 32 hospitals that deliver obstetrics in the US. Small number of them, a large number of hospitals are very small, and they deliver less than 500 babies. And they deliver about 7% or so of all babies in the US. But not only are they small, they're in geographically isolated environments. And think about how you're going to implement obstetrical care and education in those facilities. It is very difficult. Whereas almost 60% or 57% deliver in more higher volume hospitals, which they defined as greater than 2,000 deliveries a year, which I know in this center it is far more than that, like it is at our own center. And in the middle is everywhere else, between like about 35% or so in hospitals between 500 and 2,000. So the strategies we use for all of those need to be different. So we did write what the levels of care should be. This was updated. We published it first in 2015 and then updated in 2019. The problem is, until now, it has absolutely no teeth. You can say you're a level 3 or a level 4 unit, you have ECMO, you have everything, but there's no teeth around it. And the JCAHO has now joined with ACOG, and I feel this will probably stimulate it to develop more teeth, and we will be able to evaluate whether women are delivering in the right places. So I think that's a big step forward. Then we said we need to put protocols in place to look after women with the common complications of pregnancy. And we created these patient safety bundles. To be honest, I hate the term bundle, but we're stuck with it. It was a term that was coined by the Institute for Healthcare Improvement. And what it really means is when you do things the same way with no variability, you're going to have a better outcome. So essentially, that's what it is. Do it the best way, every woman, every time, and you're going to get a better outcome. I always say to our own fellows, variability is the enemy of safety. So these are, we've written a ton of them, but the rubber hits the road with implementation. And how do we implement that in all of the hospitals that deliver babies across the country? And it is a tall order. One of the great advancements has been AIM. It's a collaboration between the government and ACOG to enhance implementation of these bundles across the states at the national, the state level, and the individual hospital level. And you can see the number of states that are now in the ACOG, in the AIM network. What we've done in New York is we created in 2013, with the help of Merck for Mothers that funded our program, a program with ACOG District 2. We're District 2 of ACOG in New York. And we came together and said, at that point, New York was 48th in the nation with respect to maternal mortality. And I just said, guys, I do not want to end my career in this position. Not that I'm competitive or anything, but we're now in the 20s. But it is so unacceptable, the rate of maternal mortality in the US. We've got to do something about it. So there's 126 hospitals in New York that deliver babies, and 119 are part of our effort. And we've developed this app, and you can download it. Quite honestly, when I'm on the service, I use it every day, because I can't remember I need to go through your program, Dr. Hood, to get my memory better, but I can look up my iPhone, and I can look up the dose of the meds when I give it. Is it 10 minutes? Is it 15 minutes? I always forget that. So having that at the bedside, I think, is a fantastic tool. It's been downloaded more than 500,000 times now all over the world. So it's a very simple tool that you can use at the bedside. I can show you at the break, but I find it to be very effective, and we updated as new protocols or bundles become available. Now, with respect to models of where patients should optimally deliver, This is a condition called placenta accreta, probably one of the worst conditions you can get, and the most concerning for a doctor and a patient that is going through pregnancy together. And we know that delivery of those women in a situation where you have the optimal surgical and ICU facilities improves the outcome. And we can diagnose the vast majority of those before delivery. So there are accreta centers across the country now. That's a big step forward. ACOG put forward the pregnancy heart team, and many of us have cardiac heart teams in our multidisciplinary heart teams in our facilities, which is very good. We have taken a different approach, and it's based on our fetal center. I was fortunate to get $10 million from Carmen and John Thane, who've really helped my career and our care at New York Presbyterian and at Columbia, where we had a multidisciplinary care team to deliver patients or to optimize the health for families affected with a birth defect. I remember the words of Diana Bianchi always when she says to me, "Mary, no one doctor can look after a complicated fetus." There are now about 40 fetal centers across the country. And I began to think, why are there no mother center? So we opened in 2018 what we believe is the first mother center at Columbia, again funded by Carmen and John Thane in honor of Carmen's mother. And we bring together all of the subspecialists into the same area to see our mothers who are at risk. So we have our cardiologists, we have our anesthesiologists, and we have all of the subspecialties to try and deliver optimal care to pregnant women with a variety of conditions that we see. Certain parts of our program that we've started publishing more on is our neurologic collaboration with the Neuro Institute that's so well known at Columbia, and Eliza Miller is the lead neurologist who's collaborated with us. And something I finally was able to do was create a mental health program. In New York, you almost need to pay cash to see psychiatrists. Most psychiatrists in New York do not take commercial pay. So it's a huge access problem for us in New York. And as Kathy Wisner, who will be coming here tomorrow to present, knows, I've been trying for years to put a mental health program in our department at Columbia. Well, I finally was able to do it by a combination of grants and philanthropy, but not through the reimbursement system. So Catherine Monk, who's a PhD, well-funded, leads our program, and we now have 7 mental health care providers for women's health in our unit. But it really took a lot of effort to be able to make that happen. And finally, with respect to recommendations to close the research gaps, we wanted to recommend following the model that has been in the UK for 50 years, where they have reviewed every single case of maternal death in the UK. And not only that, they publish their findings every 3 years and what should change as a result of their reviews. I think it's been the gold standard internationally and something we wanted to try and accomplish. We really wanted to have a national review and was what we felt was most appropriate. But after a while, we gave up and said, it's not going to happen at a national level, it's going to happen at the state level. We also wanted to define what is significant maternal morbidity and near misses and look at the impact of adverse pregnancy outcome on maternal health, which is so near and dear to everyone's heart here. So these are the lists of severe maternal morbidity that are put forward by the CDC. I don't know about you, but I can't remember all of those 21 conditions. So you can imagine for the 3,200 hospitals, some of them doing very low volume, how they're going to remember it. So we put forward a very simple definition of severe maternal morbidity to be admitted to an ICU or transfused 4 units of Paxils or greater. And that's sort of your baseline. Clearly, there are much grander algorithms to define severe maternal morbidity, but if you look at those 2, you will be able to define the vast majority of severe maternal morbidity. Now, with respect to doing maternal mortality reviews on every patient, we really wanted to get this going. When I started doing this work in the beginning in 2010, there were 19 maternal mortality review committees. There are now 47. This slide is one state out of date. Yesterday I heard from the CDC, my colleagues there, 47 states. So we have seen dramatic progress. And that's been because of a number of efforts, mainly advocacy from patients that have lost their loved one. And if you haven't heard Charles Johnson talk about the loss of his wife's life, Kira, you should Google that or invite him. He is one of the most impactful speakers I have ever heard and has done a phenomenal job. He's in Atlanta, has done a phenomenal job with galvanizing Congress around responding to maternal mortality. Also, CDC was authorized to give help to all of the states to start their maternal mortality reviews. They have a single form that is very helpful, and they got $50 million recently, I think 45 million, to enhance maternal mortality reviews by enhancing review and eliminating maternal mortality. Now, they've published their data from about 500 maternal deaths from 14 maternal mortality committees that are listed in blue on this slide. And they found that 33% of maternal deaths occur while pregnant, 43% within 42 days. And you can see 23% after that World Health definition between 43 days. They are mainly due to cardiovascular conditions, and you can see all of the other conditions here. But in evaluating conditions, you must think about the race of a patient. Look at the difference. Cardiovascular, cardiomyopathy, highest in non-Hispanic Black. Mental health conditions, highest in non-Hispanic white, in this population of 14 maternal mortality review committees, where they had experts review all of those deaths. They deemed 34% were not preventable, 63% were preventable. And clearly, we are here to talk about preventable maternal death. Sometimes, even in the best situation, no matter what you do, you cannot do that. But when you think that 63% are preventable of the 700 deaths we have in our country, if that's not a major crisis, tell me what is. Now, what is the reason for deaths and prevention? We think about it in three things: denial, delay. So it's usually delay in diagnosis, delay in treatment, but there's another thing, and that's dismissal. And I was part of the governor's task force in New York to look at maternal mortality in New York, where we had these listening sessions, and we listened to families who talked about their experiences that had severe maternal morbidity, not mortality, severe maternal morbidity. And you can see what they said. I've never considered myself to be a person who doesn't listen, but when you're in the room and you hear the families talk like that, it is so impactful. And all I would say to you is all of us need to do better. And we've got to listen to our patients, and they don't feel we do. So we have a giant problem in front of us. Now, when I got into this work in the beginning, I wanted to increase the awareness of it, but I wasn't able to do that. I tried to speak with some of my colleagues at the Times in New York. They said, Mary, the problem isn't big enough. But ProPublica made the awareness in the US. And Nina Martin, the journalist with ProPublica, brought this into a national conversation. And her goal was to change the private maternal tragedy into a public health crisis. And she achieved that admirably. I was so pleased when SMFM made her an honorary member of our society, because she brought to the forefront what it meant to lose a mother, to a family, to a community, and to our society. And I'm eternally grateful for their help and collaboration in increasing the national awareness. Now, with respect to research, we have maternal fetal medicine centers. We're fortunate to be one of them, Ohio State or one of them. Mark Landon is in the audience today. I know Bill Grobman is here, that are funded to do research. But most of the research was around prematurity, and very little was on maternal health. So with this infrastructure, we stimulated the NIH and NICHD to think about maternal health and women's health as a priority. And since we first urged this in 2013, $500 million have been spent on maternal health, and also NIH added a category of maternal health to NIH-wide reporting in 2017. And we were thrilled to see the strategic planning that Dr. Diana Bianchi did in 2020, and I think very succinctly said what is in front of us. Everything is covered on this strategic plan of what we need to do, and now we just need to get busy and do it. So what do I think moving forward? I think we talked about data in the last talk. We just don't have the appropriate data, and we're all on Epic. Why can't we do a better job? Look what we did during COVID. We came together. Mike Green is here, led the efforts at the New England Journal on getting papers out quickly to publication. We had a crisis and we dealt with it. We came together. We have a crisis in maternal mortality and maternal morbidity, and we need to make it the same kind of priority. We got to figure out what's the optimal timing for delivery. Bill Grobman changed my management of all patients because he showed us delivery at 39 weeks doesn't have any difference for neonatal outcome, but lowers maternal risk. So it's now my standard to induce women, if they will accept that, at 39 weeks because of lowering the effects of maternal hypertension. And he also showed that it was cost effective, which we need to do more studies of. I talked to you about all the safety bundles we did. You can make a bundle all the time, but if you don't implement it, it's not going to matter. And we need more implementation science, especially with our collaboration where we have more resources with other hospitals. I frequently say we should be able to adopt a hospital or adopt a few hospitals outside our network and help them achieve the efforts that some of us have been able to do in our tertiary care environments. I think simulation is great, but it's expensive, it's time consuming. Where are the areas we really need it, and where is it going to improve outcome? And we need more innovation in intrapartum. I was part of the JADA device that I think will be very promising for treatment of postpartum hemorrhage, but we just don't have enough innovation around our labor and delivery interventions. As I mentioned, I think the ACOG has had a long-standing commitment to levels of maternal care, but their collaboration with JACO, I think, will give some meat on the bones, if you will, and will, I think, create some stability around maternal levels of care, and we'll be able to look at outcomes. I'm always thought about the differences between how we can tell a woman who is a baby at 32 weeks very accurately what the risks are for RDS, what the risks are for intraventricular hemorrhage, what are the chances for survival. And I cannot give any kind of information except general information to women. We've got to change that. And I think we need a population-based observational cohort study. I'm so pleased, Yoel, that you're collaborating on this with Dr. Hood, and if you need any patients, we'll supply them for you. And this is just a little example of a population study that I'm pleased that we're going to be collaborating on with Yoel. I have Uma Reddy coming from Yale to join me at Columbia in January, and we'll be looking at diabetes for 4 times during pregnancy and following those patients for a year. I spoke with Uma this morning, and we have another grant in to follow those long term. So maybe this will be a population of 2,100 women. Uma corrected me this morning, is 2,150 women who will be followed longitudinally, and we can look at the effect of diabetes over time. So in summary, as I look back, what we recommended in 2013 is kind of a positive and a negative. The positive is I think we were on the right track. The negative is we haven't moved the needle fast enough. I think we have so much more to do with improved data sources, and we need new innovation. We can create the bundles, we've done that, but we've got to focus on implementation, because as I review cases, we know what to do, we're just not doing it enough. And it's not that complicated. I think we've got to expand our research outside the walls of the hospital, and the president of the hospital spoke about that this morning, and our role in major hospitals to work with our communities and our patients and to achieve greatness. For me, a whole new area, collaboration over the last 10 years in this effort with colleagues, with my patients, with patients across the country, with advocates, has been incredibly rewarding. And I feel the data is so important, but I think we should never forget the power of patient stories. And the power of patient stories was brought to the forefront by Nina Martin in 2016. And those publications, I think, have changed everything, especially government getting involved more than any clinician could possibly have done. So Yoel, thank you very, very much for inviting me here this morning, and I'll be very privileged to be part of the rest of your conference.